press release with which the Ontario Ministry of Health and Long-Term Care introduced patient-based funding last May the 3rd. Here's what they said about similar systems elsewhere. Quote, they had improved access and decreased waiting times, improved cost efficiency, improved quality of care, and increased patient choice where they receive care, end quote. That's a pretty sweeping statement. If it's true, one can only wonder why this panacea was not introduced a long time ago. The problem, of course, is that like most panaceas, it doesn't stand up to scrutiny. The question before us is whether patient-based funding is likely to improve any of quality, accessibility, and cost-effectiveness, much less all of them. Patient-based funding has a nice ring to it. We are not favorably inclined to incompetency-based training, nor to ignorance-based medicine. And we can't imagine healthcare to be based or centered on anyone other than patients. But just as competency and evidence are typically construed too narrowly by those who employ these terms, so also does patient-based funding carry some unfortunate baggage. The argument advanced is that with funding linked to patients rather than allocated in block amounts to hospitals, they'll be forced by the tonic of competition to become more efficient. That's their argument. But there are several problems with this argument. Hospitals can be expected to become more efficient, to compete, only for those discrete activities and patients that they consider advantageous. It will not be in their interest to compete for the rest. The rest would include seniors and others with comorbidities, for whom accessibility will, as a consequence, be reduced, not extended. Fragmentation will be encouraged and collaboration across the system discouraged to the detriment in quality terms of all patients. The second claim advanced by the ministry concerns improved cost efficiency. It is difficult to see what the problem is here. As Natalie suggested, the scheme is aimed at hospitals, yet spending on hospitals is shrinking by comparison with spending on other healthcare items, particularly in Ontario, and particularly by comparison with spending on prescription drugs. Given the need to negotiate and attach prices to discrete patient-based activities, and then to document them, bill and pay for them, and monitor them for fraud, transaction or administrative costs are bound to rise appreciably. Over the short term, this is acknowledged even by the proponents of patient-based funding. The third claim concerns quality, yet the proposed mechanism measures volume, not quality. The ministry's suggestion of increased patient choice is misleading, for it will be hospitals making most of the choices. It's difficult to assess the impact of patient-based funding, especially in quality terms. The evidence that does exist has concentrated on increased transaction costs in England and on gaming and more clear-cut and blatant forms of fraud in the United States. Patient-based funding may have a positive effect on selected waiting times, although more funding and better management will have more impact. It will create and widen gaps in service provision to the detriment of accessibility. It will cost more because of additional transaction costs and increased opportunities for fraud. It does not address quality, except indirectly by promoting service privatization, which can in turn threaten quality, and by conceiving of choice in narrowly individual terms, as well as by promoting privatization, it weakens democratic control over Medicare, our best loved social program. There's a certain irony in promoting what is in effect, as Natalie has suggested, a fee-for-service approach to hospital funding, just as it is being replaced as the best way to fund physicians, especially those in primary care. Setting a rate for each activity is necessarily somewhat arbitrary and is difficult to alter in relative terms in keeping with changes in technology and expectations. And of course, in both settings, this volume-based approach encourages more volume, whether effective or not. And it is a radical change that is bound to promote instability. Perhaps that's part of the plan. Is that by pricing discrete activities, patient-based funding will ease the shift, grease the skids to privatization, and to other neoliberal tenets such as smaller government and lower taxes for governments that are inclined in that direction.